Hello, everyone. I'm Jim Garrison, and I want to welcome you to day 272 of Humanity Rising. Today, we're going to delve into the final session of our series on mental health. Just a few days ago, I saw a report from the World Health Organization saying that by 2030, depression will be the largest cause of illness among adolescents. And this was followed up by a BBC report just yesterday that was talking about a phenomenon in China where large swaths of young people are engaging in what the Chinese call lying down, where they're just simply dropping out. I mentioned this as a phenomenon in Japan that's being of increasing concern to public health officials, where young people are just simply dropping out and staying in the rooms. And this is now a phenomenon that is of sufficient severity in China as to becoming something of a media interest. Here in the United States, in Colorado, it was recently reported that suicide in several states is the largest cause of death among young people. We've all been aware, as we've traversed now 15, 16 months of the pandemic, that public health and mental health, our psychological and emotional well-being, is something that has been impacted by all of us, actually, in one way or another. And so we've taken real time here on Humanity Rising to look at how we're all doing and some of the challenges that our cultures and societies are engaging in as we traverse this extraordinary epidemic of health issues, mental issues, psychological and emotional issues, all at the same time in a pandemic that doesn't quite seem to be going away. So mental health is a crucial aspect of public concern. It's actually a national security issue in our time. One of the ways that we've tried to improve our mental health and our emotional health here at Humanity Rising is that every day we begin our programs with a little heart coherence. So I want to invite everybody to just sit back, become aware of your body, maybe take a deep breath, and place your attention on your heart. And for the next minute or two, listen to your heartbeat in a spirit of gratitude and thanksgiving that you're alive, that we're all alive at this most extraordinary moment in the human journey. Thank you, everyone. And now, with an open heart and a heart full of gratitude and love for each and every one of you who are joining our session today, I want to commence our program by just recalling one note that was in the article that I read about the phenomenon in China of so many young people dropping out and lying down. And when they've been interviewed, they said that one of the things that makes them the most depressed is the growing inequality in Chinese society and the feeling that no matter what they do, they're never going to be able to rise above where they are. And so today we want to look at this issue of inequality. The data shows that the more unequal a society is, the more public health issues there are. And we're in a world of increasing diversity and increasing inequality. So this issue of public health and the growing disparity in our societies is at the heart of what humanity needs to grapple with as we consider the kind of world we want to fashion beyond the pandemic. So today I am delighted to welcome back Lars Münter with the Nordic Health 2030 movement, and David Somekh of the Europe Health Future Forum, who've convened now, I think, 10 panels on various dimensions of public health. And with this session, they draw this particular series to a close. So Lars, David, I thank you and welcome you back to Humanity Rising.
Well, thank you, Jim. So maybe Humanity Rising sometimes resembles Pringles once you pop. So in this case, of course, even though the background of what we are talking about and the reason why we're here is extremely serious, we're trying to do our best to go through these different topics and sessions with optimism, with an intent of wanting to still remind ourselves as humans that there's so much more we can do. There's so many good things that we can do, and that we are indeed trying to do and fix some of those problems that we see in the world. In a way, I don't suppose that lying down necessarily is the most constructive way of doing that, but at least, of course, it's a way of showing something, an activism of sorts, a different way of being Greta Thunberg, I suppose, Chinese style. But today we are going to talk about inequalities, and sadly, of course, a symptom, a choice of a design of a system that we've all consciously or unconsciously been parts of creating. And this is, of course, one of the reasons why it seems both pressing and illogical at the same time. But today, of course, we'll be talking about, at the end of today's series, about sort of a conclusive remark on our sides, right, David? On these 10, or at least the 5 sessions so far in this series. But let's perhaps start these speakers, this series of speakers.
Yeah, let me make a couple of remarks though. I think that Jim made a very important point at the end of his introduction, which is that while mental health is a very real issue and the morale of society, how they're coping with the stress of this dreadful series of events, the truth is that the biggest lesson from the pandemic is that it showed, if you like, was a kind of magnifying glass on things that are already there, but which sometimes we kind of took for granted, but it really magnified them. So as an obvious example, the realities of the health impact on inequality, which were always there, and people were concerned about it for many years now in the policy world and so on. We actually saw very harshly how people with disadvantage were directly affected. More people died if they were economically disadvantaged, if they were socially disadvantaged. There's no question about that. So that inequality played a real factor, part in the impact of the disease. And the other thing I'd just comment on before we launch into our excellent group of speakers is something that struck me. I read widely as part of our future scoping, if you like, and I was very struck by an article that Reuters picked up about something going on in the States, which is that the Department of Agriculture wanted to write off the debt of about $4 billion that had been incurred by disadvantaged farmers, about 7,000 of them in the country, because there's just no way they could pay it back. And this at the moment has been blocked by 12 white farmers who have brought a court case saying that such an action by the government would discriminate against non-minority people. I think that says something about what goes on in society. It's easy for us to blame the economic system, and I think it has a major role in causing inequality, but they're also about societal attitudes which perpetuate systems that we would rather not have. But it's just a remark. Look, let's go straight on then. I'm very pleased we've been joined by our first speaker, Bob Fulilov from Columbia University in New York. Bob, can you turn on your camera? Hi, nice to see you again. We've got you've earned your 10 minutes of fame, and of course we'll join with you in discussion afterwards, but would you like to go ahead?
Yeah, I think at a moment when societal attitudes are really important, particularly as we figure out how in this country in particular, we're going to recreate the world that was partially destroyed or at least damaged by COVID-19, all the issues about inequalities, how much they contributed to the pandemic, and what we're going to do about it is really taking center stage. I do a great deal of work, and have for the last 11 years, with the issue of mass incarceration in the United States. Many of you are aware of the fact that in the US, we are 4.2% of the world's population, but as a nation, we incarcerate 25% of the world's prisoners, the world's incarcerated persons. It would be one thing if we were a nation that was drowning in crime and as a consequence saw punishment as the only way to get out of our dilemma. But in point of fact, mass incarceration isn't something that is equally distributed as an issue amongst all communities in this country. It is, more than anything else, a method of social control. And the current form of that social control goes way back to the history of this nation. Its 400-year engagement with problems created by the holding of bondage of human beings as part of slavery, a really important, often described as peculiar institution of the United States. Inequalities today that are a result of the large number of people who are incarcerated literally go back to American history at a point when, at the end of the Civil War, the 13th Amendment to the Constitution of the United States was meant to override 3 articles of the Constitution, part of the founding document of this nation, that essentially made slavery so much a part of the economic system of the country. The Civil War made it very clear that that system could not continue, so that in tearing it down, an amendment to the Constitution had to be passed, the 13th Amendment, that would abolish slavery, but would leave a back door, an exception. And what was the exception? If an individual was duly convicted of a crime. This meant that the slave labor that had been so much a part of the economic development of the South was maintained in many respects by having a large population of folk who were convicted of crimes suddenly do the work by being rented out, if you will, in chain gangs to many of the plantation owners who were so much a part of the Confederate system, who were so much a part of the economy of the South prior to the Civil War. It's important to understand that that method of social control persists to this day. And one sees it visibly in the fact that roughly 60% of the population of incarcerated individuals in the United States are Black and brown. That is to say, they are people of African descent and people of Hispanic descent. So the societal attitudes towards crime have, amongst other things, created a system that in the midst of COVID-19 was one of the major sources of infection. COVID-19 in the United States was hugely centered in congregate facilities. Jails and prisons are those congregate facilities, and they became a kind of a petri dish that would drive the infection, not just within the walls of a prison or a jail. They would also drive infection in the communities to which people returned when they were released, or to which staff members or visitors to these facilities returned as a result of having been present with folk who are on the inside. It becomes very clear that in the future, when the world is threatened by yet another series of pandemics, as a nation, we have to describe whether or not the system of incarceration that we created, at least in much of what I would describe as the post-Civil War period, has now become a reservoir of infection that we simply cannot afford to maintain. It's been really important for me, therefore, to not only sort of be engaged in the system of incarceration by training people who are on the inside, training people who are prisoners in the principles of public health. The Bar Prison Initiative, which provides people with college training if they're in prison and interested in going to college, with an enormous set of skills that allow them to return to their communities in a position to get jobs and to be contributing members of their community. The ones who focus on public health have, because of this pandemic, been incredibly engaged in understanding the relationship between what happens in a prison or a jail facility and what happens in a community, and their training about what can we do to make communities strong? What can we do to reduce the problems that create this system of incarceration? What can be done to make sure that the health disparities that are tied to that are a part of the community's agenda for confronting the issues created by COVID-19 and seeing something that looks like a promising future? I think that kind of work, dealing with a population that has been hugely disadvantaged, but giving them the skills to not only deal with the problems created by a pandemic, but to deal with the structural problems that made that pandemic so deadly, gives me at least some optimism that, at least in the future, with the agency that's been provided by folk on the inside who now want to do that kind of work in the community, that we're looking at something that not only is an idea whose time has come, it's an idea whose coming will hopefully augur in a future that is worthy of our optimism. How about I stop there? I think that's been 10 minutes.
Worthy of optimism, Bob. That's kind of words I like. Not that that David and I are sort of falling into any traps of having specific pre-designed roles, but I'm constantly being reminded that I'm basically an optimist, and David's glass is not as full as mine always. But that's another problem. But it is really nice also for you to talk about optimism, because as a point of what David said earlier, yes, we've seen enormous problems, and the lens of the pandemic on exposing problems has been enormous and really excruciating in many points. But it's also shown with this series as one symptom that humanity can rise and do great stuff. And your specific example of what you're doing is also cause for optimism. And I think that that is one of the things that you leave many of your students with. They come from a place of darkness, of no hope, and you leave them with hope. If we can go back to the case of the Chinese students lying down, that is one of the key things that they've lost, hope. And while it's wrong to say that if only we had more hope, then problems would go away and blah, blah, blah. I'm not that much of an optimist. Okay, I have blue eyes, but that's sort of the end. But still, how is that sort of also at the center? I mean, the story of the hope that rekindles the fire to make a change for themselves at an individual level, a key to these health inequalities also, to solve some of it.
Yeah, I'm very clear that there is something redemptive about education, especially for someone who's on the inside. There's a film called College Behind Bars, which actually details much of what goes on in the Barred Prison Initiative. And what you see is people suddenly discovering that in the expansion of their consciousness, by virtue of their reading, by virtue of their education, the walls of the prison almost disappear. People talk about being lost in a book, being someplace else where they can imagine a different vision, a different version of themselves, and a way of sort of moving forward that was not possible, especially in the midst of a depressing, oppressive setting like a prison. So the idea that there is hope that is born of the idea that knowledge will literally set you free, not just free of whatever shackles may surround your physical person, but free in the sense of now imagining a different role for yourself, a different position that you'll occupy in the community, in some sense that there is work to be done that you're in a unique position to do. So many people return from prison in the United States to poor communities of color, where for all intents and purposes, their loss of the rights of citizenship make their health that much more problematic. They can't simply get access to healthcare the way someone who's never gone through that experience has. Thinking that there are ways of dealing with that population, working with them to create the possibilities for health where none existed before. I think that's part of the vision that people have, and it's part of the optimism that they have that because of what has been created with their training and their education, there's a new world that they can enter, and that they can enter with a degree of real confidence.
Well,
education is a key to progress. I love it.
I think certainly I worked in the prison system in the UK, and there was an established concept of rehabilitation. There's always in justice systems, there's the balance between retribution and rehabilitation, isn't there? And of course, what I've seen sadly is that as resources get squeezed, then the first thing that goes really is the thing that really matters a lot, which is the educators, the opportunities for prisoners to, as you say, to develop, I put it in a slightly different way, to develop a means to have the self-esteem which would give them motivation and opportunity when they leave. What I wonder about is you do a fantastic job at your organization, but you are fighting against a culture, isn't there? If you have prisons that are run as businesses by organizations and so on, it's sometimes hard to get in there, isn't it?
Well, worse than anything else, that you can buy stock in private prisons on the stock market. The idea that many of these prisons have contracts with the states that license their facilities to make sure that you have a steady stream of customers, of clients, of prisoners. It's a way of sort of saying that capitalism rears its ugly head. So we're not just talking about crime and rehabilitation. We're talking about the obsession we have in the United States with making sure that for every crime there is punishment, not necessarily rehabilitation. Our system of incarceration is a system of punishment. We hate the idea that you are going to coddle prisoners by giving somebody who committed a crime access to a college education that they did not pay for. Of all the cultural biases that are present in the United States, this notion that you have to earn and be worthy of any social benefit that you get means that we're always going to deal with incarcerated populations as being at the very bottom of our national priorities. And that will create a kind of blindness when we're thinking about how to prevent damage from future pandemics, because our desire to punish will overwhelm the logic of saying you never want to leave a reservoir of infection untouched. And that's exactly what we're willing to do, because the idea that you're not even worthy of a vaccine is in many respects the kind of blindness that means that our experience with this pandemic has been the worst of just about any nation in the world, because we're not just dealing with issues of our own personal behavior. Our attitudes have kept us from dealing with solutions, even when they're right there staring us in the face. And it's a problem that I think we have to worry about for much of the time that remains on this planet.
For sure. But do you see any glimmers of hope in how you can move that to change it?
I think everything about pointing out what do we do to keep this nation from having yet another disaster that's a result of a pandemic. My hope is that at some point in time, the logic of epidemiology will help people see that it's in their best interest to not maintain a set of biases that will threaten their own health. The most important thing about the racial ethnic health disparities in the United States and the COVID-19 pandemic is that what sickened my community had the potential to sicken mainstream communities as well. We are literally all in this together. And if the logic of what helps me in the end helps you is what works out, if self-interest has a certain ability to have people see what we're currently unable to see, that it's in our best interest not to maintain these reservoirs of infection, my hope is that that logic will ultimately win out. And I'm keeping my fingers crossed.
Excellent.
But, I guess this is also a natural point to when we talk about, well, structural problems, to introduce our next speaker. And we'll go back to some of the points you raised, Bob, so eloquently later. But Stephen, talking about a structural approach to how we can look at some of these inequalities, how we can make some of these, well, logical conclusions become ever brighter and more useful for, well, not Bob particularly, but the problems that he raises. Stephen, if you will.
Great, thank you, Lars and David, and Bob. It's a privilege to follow you up. I'm going to focus, as Lars says, a bit on the structural side, but I hope to be able to put a little bit of quantitative side to the passion that you showed here. So what I've been doing over the last few years at the Legatum Institute has been focusing on what determines prosperity, what allows individuals, communities, and nations to have a fulfilled life. And I think, when you start to think about that question around, you realize that whether your starting point is health or wealth or education, the ecosystem that affects it all is much broader than the narrow starting point. So let me just share my screen and show one of the ways that we look at prosperity. To say, at one level, you need to have three things working well for a community or a nation to be prosperous. We need to have inclusive societies. I'll come back, that's the piece in the blue of this diagram. We need to have open economies where everybody can participate and contribute to the wealth generation and benefit from that wealth generation. And we need to have empowered people who are able to look after themselves, but also benefit from the resources in society so as to be able to have good living conditions, good health, which we'll focus on more today, good education, where the natural environment is stewarded for this and future generations. One of the things that I'd like to pick up on is what I've seen in our work in the last few years is that while a lot of people focus on the economy and the material well-being, the effect of if you have good resources, you can pay for health and education. One of the insights that we have found is that the quality of institutions, the level of crime, the degree of freedom and tolerance in our society, the quality of the governance, the strength and depth of the social capital have a disproportionate impact on the level of social well-being in terms of living conditions, health, for a given quality of the economy. So what we see, and I just want to pick up on what Bob was saying, is that actually the way in which we as individuals interact with each other, whether it's how we interact with each other through crime, whether it's how we enable each other to live our lives with freedom, and I want to pick up that point about agency that we look at in terms of our prosperity, because Bob, you talked about incarceration. We look at incarceration numbers not as a measure of crime, but actually as a degree of a lack of freedom. That if there's mass incarceration in a state or in a country, that is more likely to be a reflection about the lack of freedom groups in society have than it is about the overall crime levels. So what we've done is we've taken this idea, this organizing structure, and said, what does prosperity look like around the world? How does that change? What can we learn from that? And then we also dived into the US and the UK as well. But let me first of all talk a little bit about how we think about health, given that's the topic for today. And what we have, just get this to move on, is 6 ways of looking at health and trying to deconstruct it around the issues that actually affect. So we think about how do you evaluate the health of a society? What we're looking at here is things that cause people to have a certain level of health, starting with, well, a technical term, the behavioral risk factors. These are as it were, the lifestyle patterns that increase the likelihood of developing disease or reduce it. So levels of exercise, quality of diet, substance abuse or the alcohol abuse, drug abuse, things like that are controllable to an extent at the individual level, but of course there are lots of environmental drivers. Then we look at preventive interventions, which is really now getting to the heart of public health. And of course, for so many countries, this is where the underlying issues of COVID start to expose themselves. Is there a good vaccine service for MMR, TB, and so forth? Is there a good screening and testing service? So that upstream of actually getting ill and having to go to hospital to see a doctor, what is society doing to actually, in a public health sense, prevent the problem in the first place? And this is where the return on investment is so much higher than anywhere else, but yet is underinvested in. Then we ask ourselves, the care systems themselves, are they accessible? What's the capacity of the system to treat and cure diseases? Again, massive variation, we'll come on to that. And then, in effect, 3 types of outcomes that you could also have a look at. Big focus of today, and Jim led on this, mental health. So what is the mental health of society? How do you measure it? How do you look at everything from suicide rates to rates of depression to other aspects and measures of mental health? Because, of course, for a society to have good health, that is a critical part of it. I think we're all increasingly aware of the importance of that. Then looking at physical health, the disease burden in a society, and then ultimately longevity, which you could take as a life expectancy. But what we found really helpful is to break it down through the different stages of life. Because as you look around the world, or indeed even parts of the US or parts of the UK, there are different problems. In some places, maternal mortality is high. In some places, child mortality is high. In other places, it's old age mortality. And that, from a point of view of public health and an intervention point of view, is understanding the footprint, the pattern of longevity is critical, because 2 societies could have the same life expectancy 70, but as a function of very different things. And therefore, having that differentiation is really helpful. So if we take that and say, if that's how we sort of think from a point of view of measuring health around the world, what does it look like? Because the first level of inequality that I think we need to recognize, and I want to sort of pull out from the initial conversation on the United States, and we'll come back to, is to say, look, the big inequality of health and in so many other parts is at an international level. Interesting, if I were to put this map together where the dark green are the more successful nations, the dark red are the less successful nations, on whether it be health, quality of an economy, quality of governance. Problem is, to a huge extent, it's nearly always a very similar picture. And what we see here, is that places like Western Europe, interestingly China, Australia, high quality health. North America, actually less so. And we can come on to that, the US itself. Stephen thinks he's screen sharing, but not.
It is.
You're not seeing it? Is that not coming up on the screen sharing? Oh, it is, okay.
No, it's
we're
being
seeing it.
broadcast, Stephen. We're seeing the broadcast.
Right, love it, okay. So health around the world, what you're seeing there, and the sort of really flashing red signal, is Central and West Africa. And that is for a number of reasons, not least to pick up on the comments about that come through on the chat around trauma from conflict. So this is not just overall health, but we see a similar pattern in mental health where so many of the countries in that deep red have experienced conflict. And that has an obvious effect on health infrastructure, but compounded with levels of trauma. And that we're really seeing that playing out. And you see further down in Southern Africa, Zimbabwe, which has had a huge amount of trauma. And I've done some work in Zimbabwe on studying this issue. And there are really harrowing stories of how through the last 40 years of both economic collapse, but also the Gukurundu massacre in Matabeleland or other traumatic affairs have meant that actually you've got a society that struggles to thrive from the very basic point of their lack of self-confidence. Their history of struggle is really still affecting them. So what I think we can see here, and I really wanted to bring that out to a global level, is that sort of the inequality that we need to worry about is not only, say, within the United States or within Western Europe, the UK, whatever, but around the world, this inequality is very serious. And that while a lot of aid goes into this part of the world to support people and to help them, not enough effort and not enough investment is going into public health in these countries. Public health is often so determined on good government, good governance. And that's one of the real tragedies, that the return on investment in public health in these areas is so high, but we don't have the infrastructure to support it. So if I then turn to the US and say, what are the determinants of health? So if we think about health as being sort of an outcome of not only the health system, and as we said, the sort of behavioral risk factors, we hear a lot about social determinants of health. But actually, if you broaden that out, start to realize there are social or economic or institutional determinants of health. And from our examination of our prosperity index and looking at it across the 50 states of the US, we're able to start to see what is most correlated with good quality health. And on one level, it's no surprise that things like living conditions, the quality of the natural environment, people's sense of freedom and agency, and good levels of tolerance and lack of discrimination, and of course, education has a massive, massive benefit. But beyond that, the strength of social capital, the level of safety and security in the community, the quality of its governance, the business environment, the infrastructure, the economic quality. Do you actually have a functioning society that provides a labor market for people to earn their own way? These all have an impact on health. I think one of the remarkable things when we think about this and look at the US, which you will see on the next slide, is the variation of health across the country. And there's a red zone in the US. Obviously, the differentiation is not quite the same as you have at a global level. But that little focus we had in West and Central Africa, there's a considerably comparable focus that needs to be addressed within the US as well, as you can see for some of the southern states. And what we see is big variations as well within states as regards the pattern behind it. And this is where this level of quantification can be enormously helpful. Because if we take California and we take Iowa as two states that score well overall on health, they've achieved that level of health in their societies through different pathways, as it were. So California has the best longevity of all the 50 states plus DC. But on the other hand, it's actually got pretty moderate preventive interventions. So the level at which there's screening going on, there's vaccination, things like that in the public health sense, pretty moderate, pretty poor care systems when you think about the proportion of the population that gets good access to healthcare and the quality of that care. On the other hand, when you look at the behavioral patterns in terms of the levels of obesity or the levels of exercise or the levels of smoking, that's all. It starts by having a very healthy set of behaviors for many people, but the system itself is not helping those who fall ill in the way other states do. Whereas Iowa has much poorer rank in terms of behavioral risk factors. So people on the surface appear to be living less healthy lives in Iowa, but on the other hand, much better level of preventive interventions, much better level of care systems. So as a way, if I were a disadvantaged person who perhaps didn't have the opportunities to get a better diet and so forth, I would actually be cared for much better in Iowa than I would be in California. The other thing to note, it's less visible here, but this issue of quality of institutions is very important, because what we see is that places like Mississippi, Louisiana often have wealth associated with them, to a moderate extent, but poor institutions. Whereas Vermont has very good institutions. It's not the wealthiest of states, but as a result of its good quality institutions, the education, the health of someone like Vermont is so much better. So the Vermont system has a much better return on social investment because of its high quality institutions than some of the southern states. And in effect, when we look at the UK, I won't go into any detail, but this is a pretty similar picture. A healthy southeast of the UK, which is probably California-esque in terms of a lot of its characteristics. But then as you head further north, particularly the industrial heartlands, just north of Wales and Liverpool, Manchester, that is a much weaker place from a health point of view, massive disparities. So when we then say, okay, let's go beyond the geography, because geography gives us a first order view, the real inequalities occur at a lower level. So if I just pick longevity as an example, I think what we see, if we look across different counties in the US, or take it even more granular level, and look at the counties, if I were to break counties up into groups according to the racial and ethnic diversity of the population, and look at those with sort of low proportion of African Americans to those with high proportion of African Americans, what you see is a pretty stark, these are not life expectancy numbers, these are scores, but you see a pretty stark reduction on the left-hand side in the longevity score in those counties with high minority populations. And that's including all the people who live in those counties, even more stark when we look at it from a pure population basis. You also see that actually what's interesting from there's an urban-rural divide we mustn't forget about too. And funnily enough, given that those rural counties are mostly white majority counties, the racial skew is even greater. So what we need to do if we really want to solve the health problem is understand the institutions, but also get under the skin of the much bigger disparities that exist below that surface level data. And this data now has been used for county health assessments by partners of ours in the US who are able to get under the skin of it into very great detail and start to map out not only sort of counties within states that have challenges, but also which communities within those counties have what type of challenges. Is it an exercise, obesity, diabetes risk factor, or is it a lack of access to care, or is it a mental health problem? And really laying all this out, we hope can start to give decision makers a much clearer view of the world. And if I go to the UK just to finish, we see exactly the same patterns health disparities. So on the left-hand side, looking at pre-COVID, they're all pre-COVID. The prevalence of long-term conditions for those over 55 is skewed towards the minority population. And that's, to the point that David mentioned earlier about, who was at risk when COVID hit. It's those with the comorbidities. And those with the comorbidities are clearly coming from disadvantaged communities, whether it be an ethnic lens we put on it, or whether it be a socioeconomic lens. We see the same pattern coming through. And without getting this really into the right level of granularity, into the level of decision makers, we will always fail to solve this problem. But then the question, this comes back, I think, to institutions and society, is when there's an effort then to respond, as there has been in the UK and many places with vaccines, is that we haven't found the route to ensuring that all communities and all people get equal access to the vaccine and equal take-up. So this is slightly out-of-date data now, but one of the things that we were looking at was who gets vaccines. In the UK, given it's the National Health Service, it's a public health system, it's in theory universally available, definite efforts to outreach to different places. But for whatever reason, and it's worth considering what those reasons are, that effort has not been as successful in some communities than others, whether that be a case of institutional trust. If there is a history of a lack of trust of officialdom, this will bear down on how people respond. There are other issues about language, about communication, about reaching into certain communities. But to pick up what David said about the pandemic revealing, this slide here reveals not only an issue around vaccination rates for COVID, it reveals an issue that we see elsewhere about vaccination rates for other diseases or access to public health systems. So there's a lot more work that we feel needs to be done, and certainly we're keen in the next few years to sort of surface more of this, get it in front of decision makers to sort of force a reconsideration of how the system operates. I'll leave it at that and stop sharing.
Thanks a lot, Steve.
A tour de force, Steve. Stephen, it will take a few weeks to actually borrow through all of that data-rich material too. And you've certainly been very busy at the Institute. It's fascinating to see those differences where you can see that given actually sometimes quite similar circumstances, you can actually do a lot with it, given other choices also. So it's not per se always deterministic in the sense that you can only go one route if you have such and such circumstances. But in the interest, though, of time and talking about transformation, I think we should move on to our next speaker, because that's definitely talking about systems transformation and how some of those good data that you have, Stephen, can be used for good effect. And we have a session at the end also where there's time to dive a little bit into those data too. But Anna?
Yes.
Yes, you're here with us. What of course Stephen here has described is a lot of intricate meshes and machineries and such that interlinks. And sometimes I guess you can become blinded by all of the scale of things, but still you dare to think about systems transformation at a large scale and systems design. So please enlighten us a little bit on how you can actually think daringly about these big issues.
Thank you very much for this this introduction. I'm going to be a little bit humble about my contribution, but I'm delighted to be here and to follow up on Bob and Stephen. And indeed, Stephen has given us a fantastic overview. So just to say from which side I'm coming, I'm a public health physician, so a medical doctor who is specialized in public health. And I should really start with the definition of public health, because I think that has a lot of clues to what we're talking about. So the definition of public health, and this is adopted by the WHO, is the art and science of preventing disease, protecting health, and prolonging life through the organized efforts of society. So I think there is a lot of richness in that definition, and that is really the lens that I'm looking at these issues. And today I'm going to focus more maybe on the art, since Stephen has produced the science so beautifully. And the main thing I think from the public health definition is through the organized efforts of society, that last bit, because that is really the practice, the art of public health. And I think nobody will disagree that most of the public health issues we are observing nowadays, whether it's climate change, obesity, anxiety and depression, health inequity, have emerged from the way how we have organized our societies, whether it's nationally or globally. The economic, education, employment, and social care systems, how we have put them together. It's we have done that. We the humans on this earth have done that. So if I can today share with you the reflections on this, is really that the major change, the major transformation that we are actually doing already with COVID, of course, is that we need to value health much better. And we need to take the threats to health seriously. I think if we bring it down to a very personal level, you only value your own health once it's gone. Once your leg doesn't work because you've broken it, only then you actually value your leg when it's not broken, when it's healed. So we persistently, on individual but also a national level, undervalue our health. And I think that is a mind shift that we have to pursue as COVID has started to give us that little push, or maybe a big push. So so COVID is really the mirror that is showing us this value of health. And in that sense, there is really something to say about that. We need to reimagine health. We need to reimagine health as a common good for everything that we do in a society. So if I just can narrow it down then to the health system, reimagining the health system, I think the three major shifts that I would like to touch on is the shift from actually a health, towards a health and well-being system, rather than what we actually now have is by and large a disease system. So really shifting to the health and well-being, and also the wholeness. So the whole being approach, both our physical and our mental health, our body, mind, and soul connection, that we really think of in that wholeness, through that wholeness lens, when we look about how we want our future health systems to look like. And with that comes back the definition to public health, the proactive, the preventive, the health promoting aspect of our health system needs much more attention than what we have put towards so far. The community approach to our health systems, the very strong fundamental primary healthcare approach to our health systems. And also for me personally, I think there is a mind shift around the starting point. The starting point of a health system is really the highest potential of people's well-being, not their disease. It's about well-being. So that's the first shift that I hope to see happening more and more in the future. And then the second shift is really that whole of population approach, that we take everybody with us on that journey. So Bob very poignantly highlighted the prison population. These are people in our society that have just as much right on health to health as everybody else. Health is a basic human right, and we are all equally humans. So that is, I think, really something that we need to much more have at the forefront of our mind, that we're looking at the whole population. And of course, within that, in public health, we do look at the most vulnerable in our societies, but we want the outcome of our intervention, of our work, be that the whole population is healthy. And since we're talking today specifically about inequalities, I think from my perspective, the key word in that element is health inequity, because inequalities are observable differences. But when we talk about health inequity, it means avoidable differences in health. They are avoidable by the way how we organize our societies. So this is the prevention side of the health service, of the health system. And then the third shift, major piece of the puzzle in terms of reimagining the health systems, from my perspective, is really take that full determinants of health approach, and the social, the economic, but also the commercial. We're seeing much more discussion about the commercial determinants of health. And I really liked when Stephen, showed us also that outer circle of the determinants of health, where we have the social capital, the governance, in how that is such a big hold on our health. And so with that bit, I actually come to the kind of systems innovation aspect of this all. It's not enough that we get better in being medical doctors, and I think everybody will know this intuitively. So we need to work towards that innovation, reimagination in our systems, and then I would like to share maybe some 3 reflections on how do we do this? How do we do this reimagination? So clearly, the first starting point is thinking about that at that systems level and seeing the whole system, not only the health system now, but the wider system, and seeing where and how health is created and where are we harming it? Where are we actually harming it actively with our policies? Because we maybe value economic growth more in that part of our society. And I think we all are really on a big journey to learn about whole systems thinking and whole systems innovation. And I recently have seen quite a lot of thinking about how do we unlock those systems that are very solid because we've created them over long periods of times. And there are kind of 4 keys that, for example, the Rockwell Foundation has been discussing, and I really resonate with that. So one of the keys to unlock a system is looking at its relationships, changing the relationships between the constituents parts. Because when you change the relationships, you change the flow of everything. And I will come back to it in my second point. The second key where you can start unlocking the system is its power distribution. If you change the power in a system, the system starts to rearrange itself differently. The third one is its purpose, and that for me resonates very much. Let's rethink, what's the purpose of our economic system? What's the purpose of our education system? And maybe we should really think how health fits in that purpose as well. And then lastly, the flow of its resources. The moment you put resources somewhere else, for example, to public health, that attention starts to flow to that part, or it will start to rearrange its system as well. So those 4 keys are a starting point if we want to relook and enter a system and start to shifting it. So relationships, power distribution, purpose, and resources, the flow of resources. But the second part, the second aspect, I think, which is really important, and it has been already also said by Bob, I think, it's about participation, about inclusiveness, about diversity, about our collective wisdom, about co-creating those systems. And participatory leadership is so important in that. And participatory methodologies to really be able to bring people together and hold that deep dialogue, our listening skills and learning from each other is something that we really need to get much better at if we want to have a good chance on redesigning our systems. And then, so with the participation, and I think this is where the Humanity Rising context comes in so beautifully, we need to start reconnecting at that human level, because only then can we really work together towards these new emerging systems. And NGOs, I think, are incredibly important, for example, in my work, when we're looking at system. And then the last part is really that reimagination. I don't think we are usually asked in our jobs to bring our imagination at the table. We are asked to bring our expertise, our numbers, our data, but our imagination. What about the wisdom that sits in us? So combining, what if we can combine the science and our inner knowing, our wisdom, our lived experience? And I'll leave you with one sentence, because if you want to change the system, you can only change it if you understand it. But you can only understand it once you start interacting with it, engaging with it. So we don't want to start looking at a system and redesign it in one go and implement it. What we want to do is start learning by doing, by small actions, prototyping, learning from that, and moving from one step to another. And I will stop there. Thank you.
Good advice, I'm sure, Anna. And for those of you that follows Anna perhaps or via LinkedIn or can find her, I can encourage you to do so, but also to dive into a little bit more about the storytelling, but more about the good story, or at least the story, David, from our next speaker.
Yes, we again, it's very appropriate that we follow Anna's tour de force in terms of the things that help us to change the system, which actually, if you look back on the sessions that we've been doing, there are elements repeated throughout those sessions, which so it was a lovely summary in a way of some of the messages we brought. But Rebecca Mulby is a professor of health systems innovation, so it's a natural follow-on for you from what Anna was saying. But you've got a particular story to tell us, I think.
Well, I'm going to tell you a little bit about some of the work we've done over the pandemic in the UK, and I've worked all around the world, and I would say that there are very, very strong similarities with everyone I talked to. And the first thing was really just trying to understand what was working. So in the sort of horror of it all, was anything happening that was actually good? And what we saw was that in parts of the NHS and in parts of services throughout the world where things were working or people were managing in the pandemic, then they were doing it because they were taking on all the lessons learned from high-performing health systems. So what we saw was that that staff, people who worked in the health system were being properly valued. Everybody was learning. Everyone was trying to share information as quickly as possible. There was data that helped people do that so they could really get it quickly. People worked in real close collaboration in their community. Health services were asking for help. The core basics and efficiencies were sorted. But over time, particularly in this country, which is, I think, the most hierarchical democracy in the Western world at the moment, we saw power being sucked back up to the top. And the things that had probably shifted the most, which was particularly around collaborating with communities, was the thing that was starting to go back. So communities and people were being the least engaged rather than the most engaged. So having been a solution during the sort of crisis of the pandemic, then the little people were being sort of put back in their box, really, and said, thanks very much, that was very helpful, but we don't need you now. And that's really fascinating because, of course, that was fine until we needed to vaccinate everybody. So we had a lovely expose about where COVID has hit hardest, but put simply, it's where people are poor. And so really underlying our response here is not just around inequalities, but it is around racism. The structural racism that exists certainly in our society, which means that we can't see people, we can't see the problem. And you know that you will have done some work on systems change, I guess, and you know that you can deal with the events, you've got to look for the patterns, then underlying that, what are the generators, what are the causalities? Well, what we saw and what we're exposing here today is the pattern of people who are poor or who are black or brown are getting less access to health care anywhere. And that isn't by accident, that is by design. And we have to really own that. So where do we start? And I don't know whether you remember this Tolstoy quote, but he said, I sit on a man's back, choking him and making him carry me, and yet assure others that I am very sorry for him and wish to ease his lot by all possible means, except by getting off his back. And that's, I guess, the struggle that we have here, which is the amount of invested interest and the lack of real concern people have for other people. And it's lovely to see here how concerned you are for each other and for humanity. But we have, as a health service in the UK, been really complicit in this issue around the lack of universality of healthcare. And I completely agree. It's not about tackling inequalities. It is about getting right underneath what we're doing to compound it. And so there are three things we're doing at the moment in the NHS, which is making things very obviously worse. The first thing is that we're medicalizing poverty. So if you go to our primary care health system, you'll find that about 40% of the people that turn up frequently are there because they're poor, they're struggling with life. And there's no amount of GP appointments, general practice, nurse, doctor, any appointments are going to solve that. In fact, actually, what you're doing is you might just be holding somebody up enough so you can go back into a truly awful situation and cope. Now, I don't think that's right. And I've been calling on the Royal College of GPs to do some work in this country to expose the amount of time the NHS is spending propping people up who are poor. How much is the NHS spending on that? And is that the right thing to do? Because actually, if we spent that money on giving people a universal income, as we just have done through furlough and the pandemic, we've experimented with a universal basic income for all. What if we just did that? What if that was our solution? But all the time, we try and do the thing we think is good, the thing we think is right, which is help people through. Helping people through doesn't therefore give back to the parents the problem, if you see what I mean. So for me, there's a real issue around we are not explicit about why people turn up for healthcare and what their issues are. The next problem that we've been complicit in is rationing. So the pandemic has meant that very significant services were put to one side because of the urgency of COVID. And that's still being played out now, right now. So whilst we have our third surge in the UK on its way and in these sort of early foothills, already we know that that's going to lead to people being hospitalized and dying. And then who says who takes priority? So in a service where we don't have enough capacity, how are we rationing? And we're rationing by disease. We're not rationing in any way that is accountable to the people that pay for the service. which is the general public, because we're a taxation-based service. That's the second way. The third thing we do is we design services that people can't access or don't want to access. So if you have a look at how we design, for instance, services for young people, if you look at how many young people turn up in primary care in the UK, the 7 to 24-year-olds just don't go. Now, primary care is being given £95 a head per population to provide primary care services. You're telling me those young people don't need anything? I don't think so. So it isn't just around health inequalities around Black and ethnic minorities or poor people. We're also not very good with young people, as it turns out. So what happens? Where do young people go? A lot of them go to out of hours services or go nowhere. Now we started off this session today with Jim on mental health, a very significant issue for young people. And what we find is that you'll have your young teens who know their friend is self-harming, who have nobody to talk to about it and have no idea what to do about it. And that self-harming person is invisible to everybody. The burden being borne by their friend. Now, how are we designing services based on need rather than based on historic patterns? And you can't have a situation where a family practitioner can say, well, if they need it, they'll turn up for it, because that just isn't the case anymore. We haven't thought through what's the need and how best to design it. And that goes for how people can get to health services in the UK. So when you look at who turns up at outpatients or hospitals or wherever, we have all this category called hard to reach. I don't know if you have that in your countries. People who are hard to reach are people that we can't seem to find. We don't know how to get to them. They're very difficult. They may have diabetes and come from an Afro-Caribbean background, and we assume that's because they're of their race, not because of their diet or the fact that they're poor or the fact that no one's taught them how to cook in a different way, or anyone's had any conversation with them at all about what's your income, what's your context, and how do you cook food in a way that's going to help you not to have diabetes. Why don't we do that? Because they have to go, let's say it's a mum with several kids. That mum on a universal income of not very much might need to take her kids on several buses to get to an appointment at a surgery to be told by somebody that her blood sugar's high. She knows her blood sugar's high, and she's going, that round trip in terms of time and money is not worth it. So how amazing that apparently when we do want to reach people, which we did with the vaccine, we've gone hell for leather in this country to vaccinate people. And we've done that in the most creative ways by working with communities. So actually, it isn't these people hard to reach. They were easy to ignore. And that's a very significant difference. So actually, we've chosen not to provide services to a section of the people of this country, because when we had the vaccine, we have vaccine buses, vaccine taxis, we have immunization, all sorts. We run sessions in mosques, we run them in the street, we run them in circuses with circus folk helping us. Apparently, we can be phenomenally creative to find ways to encourage people to be vaccinated and to get the vaccine to them. And so when we're looking at the round, I would say that our health services are complicit in all sorts of potentially well-meaning, but mostly just unthought through ways of ensuring that the people that are hard to reach stay hard to reach, because really they're easy to ignore. So that's what I really wanted to cover in this session, that we've chosen ways of designing services that mean that we do not have a universal healthcare system in many countries around the world. And we have to tackle the fact that that's a choice.
Thanks a lot, Rebecca.
Yes.
I must say, I love that quote from Tolstoy. It says a lot. And I think it chimes as well with something Anna was saying, wasn't it, about what keys you need to unlock a system that is, and that's something that you know a lot about as well, about how to produce innovation in a situation where there are very rigid and self-serving systems. I mean, it's hugely challenging, isn't it?
I mean, I think that what we do is, I don't know if you read anything around Mark Moore or HiFix, but there's some very nice stuff about delivering people's duty to them. People don't always do what their duty is. And sometimes you have to just make it impossible to walk away. And that's why we use data quite a lot to say how fascinating, or stories, how fascinating that these hard to reach people, you can vaccinate them tomorrow, but apparently you can't run a diabetes clinic for them. Why is that? Or how fascinating that you've chosen not to provide any primary care services to anybody aged 7 to 24. No, we haven't. I mean, they just don't come. I said, no, you've chosen to, because you are being paid for them. So I think that sort of, delivering people's responsibility back to them, make it obvious, make it very hard to walk away from the problem. That's how we tend to tackle it, which is, Heifetz would say, you turn the heat up.
It's the power of narrative. Look, shall we ask the others to turn their cameras on? And we've got some minutes.
Yes, indeed. And some of these elements that you point to, Becky, surely, Bob, you use some of the same tricks, I suppose, from time to time, right?
Of course. Yeah. Logic is not enough in too many instances.
And the fascinating thing is, of course, also to see how that translates into some of the data that you have, Stephen. It's sort of a constant. It's not a yin yang, but it's a positive or it could be a positive feedback loop. Let me phrase it like that. When you have better data that allows you to make better choices, also now in the service of equality. It's those data also that makes choices what Becky describes possible. And I think maybe that's. Yeah. Sorry, Stephen. Yes.
I think there's the old adage of what gets measured gets managed. But I think what Becky was bringing out was something really important, which is sort of at the edges of the system where the informalities and other drivers are important. Is where it breaks down. And I've seen that when looking at the education system and looking at racial disparities in the education system. It's all those areas where there are judgment calls and discretion that in effect don't get measured, don't get reported, is where you see the problems. I think Becky was sort of giving another example of this, that sort of, I can get 80% of my population vaccinated, but there's decisions and judgment call and discretion and imagination I need for the other 20%, or that doesn't really get measured, therefore I'm not under the cosh to do it. And we have to try and expose that, and it's where people have options and discretion that the duty to perform is often sidelined.
Well, of course, that's one of the reasons to have that call for many, many years in the WHO and the health and old policies that we have to go closer to the edges as much as possible. I remember a wonderful story from a Swedish friend who knew that he had this lawn, a beautiful lawn, and anyone who knows Swedes knows that they really care for their lawns. And he used to mow it with his neighbor. They had a beautiful lawn, but the new neighbor wanted to set up a fence. Now neither he nor his neighbor could actually really mow the lawn. They had a clear line of demarcation about who's actually had the responsibility for which part of the lawn, but it looked like shit.
Yes, I think what we're experiencing very much in the kind of whole of government approach to health, that the Ministry of Health is always the poor cousin of the government. They have the lowest budgets, the least to say, and I really hope that with the COVID experience, however painful it has been for everybody, and for some people even worse than others, that maybe we have learned a little bit that we need to have a much more coherent policy approach to how we look at health indeed across all the different ministries. And this is where I'm talking about the different purpose of our systems. What is really the purpose of our economic system? Is it to make us richer and unhappier? Or is it actually there to make us more happy? And what we measure, indeed, I think, going to the Bhutan example of the gross happiness index, or the other indexes that are coming to start to replace our GDPs, which is not really fit for health purpose. It would be really, really nice to see in my lifetime.
Yeah, but at the other end of the scale, maybe, Anna, I think it's a question for you, Becky, and you, Bob. Some of these data, these systems at a national level, but when you make judgment calls and so on, that's often at a very individual, granular level. What are some of the key advice you can give to people who are working at that level to break out of that mold? Because, I mean, they're hard to catch those judgment calls. They're hard to call out. What do you normally do or advise people to do?
You know, one of the things I'm fond of pointing out in that what gets measured gets managed. How do you measure an illness that you've prevented where you've got nothing to count? I think the big problem with public health is that when we're really good at what we do, prevention guides almost everything we do. It helps us figure out where to put resources. But how can you point to prevented cases of this or that and then have people say, ooh, let me give you more resources to do this? I think Anna's point about public health throughout the world is always the redheaded stepchild, is the term we like to use here in New York. Because it doesn't get anything because it's not sexy. And because if we are depending on measurements that tell us how much we need to do where and when, our best work doesn't produce the numbers that would help us get that. And I think having people think about other ways of going about it, appealing to fear, for example. I don't know whether you follow that literature on whether or not fear works as a way of sort of getting people inspired to do something. You remember that in the United States, Surgeon General C. Everett Koop sent out a mailer about HIV/AIDS in 1988 to every household in the United States. It gave the sense that we were about to be basically with HIV in the same situation we found ourselves in with COVID. What happened? 2 years later, it suddenly becomes clear that this is a disease of marginalized communities. Mainstream America simply didn't see it. And they said, you know, this whole HIV thing, I'm not really clear that it was worth the time, the energy, or the sound and the fury that we directed at it. So I want to just acknowledge that I don't necessarily have answers, but I certainly see the problem. And the problem really does have to do with this: if it gets measured, it gets managed. It's too narrow a way for us to do the business of public health.
There's a really great director of adult social care in Leeds who managed to persuade his bosses that his performance metric for the year would be how many more people in Leeds had got more than 4 friends. And it was based on and it had a strong evidence base, which is the people who have more social contacts access the NHS less. And that's the work that was done in Torbay. It's been done in Leeds. So some of these things are proven metrics. And then could you imagine trying to ask anybody, any health professional, to measure their performance in relation to how many friends they've got? But we're trying that. So I think sometimes you're right, Bob. You get more of what you pay attention to. So that's certainly the first thing. But the most important thing is to remember who pays for you. And so, you know, if the payer is your local community, stop holding yourself to account to some central bureaucracy. Hold yourself account to local people. It creates a ring around you that enables you to do so much more. So properly collaborate with a community that loves you, because everybody loves the health service. And people are very tolerant of the fact that you're trying to do a very difficult job in very difficult circumstances. So they just love the fact that anyone is talking to them about it. So if as a health service, a hospital service, a community service, you go and say, look, we've got these difficulties, we're trying to do this. A, can you help? People always step in. But secondly, this is the way this is our story about how we're trying to navigate through that. But we're having a bit of trouble because we're being told to do something else. But we really think this is the right way. You know, would you help? What do you think? Oh yeah, we'll write to our MPs. You know, so I think we just do not use, it's a bit like Anna was saying about where is power. Power is really held in ideology. It's not held in position. So every time you keep reaffirming positional power, you're losing the power of the ideology. And that's where we have to go.
I think there's another ideology, though, which is that you touched on, Becky, when you talked about duty of care, you know, which is, if I understood you right, you know, which is, of course, the moral imperative. I mean, it's about the ethics of all of this, isn't it? And whether people are invested in the notion of care. And it goes beyond the health system. isn't it? I mean, one of the things I liked about Anna's approach is, of course, it linked with what we'd brought to at these webinars previously about the wellbeing economy, and the notion of that is growing in strength really across Europe and perhaps elsewhere in the world. I know places in the States experimenting with this, where the needs of society become the focus of what the economy should be about. Now, it's a long journey to get there, to be accepted by those who've got a vested interest in the status quo, but it makes so much more sense because it also then, it cuts across the silos, isn't it? So we don't just look at health in the narrow context of a health ecosystem that's about the system itself, but linking it to the environment, to social justice and so forth, and the sense that everyone can get involved. I mean, that's the other thing that, the way Becky was talking about, people are open if they can see the point of it, and if they feel that there's something, after all, they're only human, there's something in it for them as well, and people all understand about being cared for. I mean, most of us are lucky enough to have parents or people or carers, people who made us feel wanted. And this is, I mean, it sounds all very woolly and whatever, but we know, as Becky was saying, these are very real things because they have impact. What happens to people, their health, their social relations, the structure of our society. That's my lecture for the day.
Well, it's time now, I suppose, to thank our great speakers for once again providing us and our participants with some great insights, some few select and key experiences and advice. For me, I'll try not to lecture, but at least I'm constantly reminded of hope and the idea about using agency at any level with what I normally call systems leadership. If you can do, and remember that you can do, that's a very important lesson. We've in this series we've talked about health literacy. We've dived into digital health. We've gone to talk about mental health as well. It's been a pleasure again to talk about all of these different issues with these wonderful panelists again. It's especially been very rewarding to see how different elements from across the globe, from across sectors, are challenging the model, doing what we can at various levels to make a difference for, well, our fellow human being. To this, actually, what are some of the key learnings, David? I know that there must be some optimism in you as well.
I wouldn't be here, would I, if there wasn't optimism? No, I think the key learnings, I think, is just how we've been so lucky to have such a rich group of people, not just today, but throughout the sessions, who show that they're all working in their different ways to try and change the system and challenge it. To me, that's what it's all about. We can go endlessly about what's wrong with the thing. It's too easy. It's how we're going to put things to make a better world, and that's what counts for me, I have to say. Even though I am world weary and cynical and so on, I mean, the fact is, hope still lives.
You hide it well at times, yes.
I'd love to ask Jim now to join the conversation and just reflect with us on how you found the last few sessions. I mean, sure, you've constantly emphasized the mental health issue, but we know you're a wise man, that you're well aware of all the other ramifications of the things we've looked at. What's stood out for you?
Well, what has stood out for me in terms of the sessions that you've brought together is the dimensionality of public health. I think up until your panels, I had a rather one-dimensional notion of public health. It was sort of the National Health Service. You kind of go there when you're sick, but you've really teased out not only the different aspects of public health, but the importance of public health. And to your point, Anna, earlier, how much of our health services are reactive to treat a disease once it's surfaced, rather than proactive to prevent the disease in the first place. And, I loved your last point, Bob, that, if you keep people healthy, there's nothing to measure. And it reminds me, we had a panel on Regenerate Costa Rica a couple of weeks ago. And Ed Muller, who's the president of the University of International Cooperation there, told a story that there was a region of in Costa Rica there that was poor, been hit by the pandemic. People were suffering from mental health. So the government set up a mental health clinic where you could go and people were using it. And sometimes there were waiting lines because people were just desperate. And what Ed and his group did, they went in and set up a little farming operation to regenerate the area. And people started to get into farming, and they began to realize that the species of insects and so forth were coming back to the area. Everybody started to really engage, and there started to be parties, and nobody was showing up to the mental health clinic. And finally, they shut it down. And nobody did anything other than to take your advice, Anna, to, live life. And to your point, Rebecca, that, we're 4 or more gathered together, you don't show up at the NHS. It's this, and I can say personally, since Humanity Rising started a year ago, we've been broadcasting every day. We've probably had upwards of 1,000 speakers come through our sessions. I've interacted with almost all of them, at least the conveners. And so my interactivity is at a higher level than I can ever remember it being in my life. And I feel more energetic and more abundant and alive than I can ever remember being. And I think it's purely because my sense of community and my sense of friendships, like David and Lars, I consider you friends. I mean, you've done 10 sessions on Humanity Rising, and we're in conversation, and now we're thinking of a whole new program in the future, and that makes me very happy. And so for me, I think the takeaway is that the more we live large our lives, the more abundant we feel and the more healthy we become. And I've really seen that more clearly through your panels than previously. So I really want to thank both of you for the work you've done, and look forward to deeper collaboration as we move forward. I would make one other comment, which I also think just needs to be said to what Rebecca said and what Bob was saying. And that is that, how to put this, the diseases we're inculcating in our societies are by design. It's not that we have kind of random societies and people kind of get sick. The institutionalization of inequality, particularly around race and the poor, by design, is, when you really understand the gravity of what I just said, is almost so shocking as to be unimaginable that in the 21st century societies would organize themselves around a social architecture that foments disease. And for anybody that wants to explore this deeply, I would recommend they read Michelle Alexander's book, The New Jim Crow, where she shows that the intentionality of racial design in the United States is embedded in law consciously. And then the derivatives that happen to the poor and the people of color are by design as a mutual reinforcement to the racism that designed the laws in the first place. So I think all of us, wherever we are, know the abundance that comes from kind of the free, happy, abundant association from individuals coming together in community. And many of us live in countries where the design of the country precludes that happening in the way that is necessary for truly abundant public health. So that would be my kind of takeaway from these sessions. And I don't know whether anybody wants to make a quick comment on that, but that's been my impression of what you've put together. But at least Lars and David, I'd love to have you just make final comments as we close out the session, because you've really worked hard, and I just want to honor you and salute you.
Well, I think that it's worth remembering, though, that designs can be changed.
Yeah.
That indeed these are not laws of nature, which can't really be changed. We don't know how to do that yet anyway. But these are things that we can indeed change. The minute that we think that these are beyond our control, that's when we really lose. So remembering that as these are human designs, they can also be changed.
Yeah, I absolutely. I always, boring as I am, I say the same thing, which is often when we feel oppressed, by a society that is cruel or is treating people badly, I always talk about the underground. In a totalitarian society, humanity always lives still. It lives on the edge and keeps the spirit alive. And I think this is something we all bear in the back of our minds, that we, even when it seems like, well, this is just such an impossible hill to climb, that just what we're doing matters because we're keeping that flame alive. That's my bit.
Yeah, absolutely. Thank you, David. Thank you, Lars. Bob, Rebecca, Anna, Stephen, thank you. This has been very deep and a very profound closure to our deliberations on public health. I appreciate it. Then tomorrow, everyone, we'll be turning to the issue of how to be a good ancestor as we think about the future. So that'll be on Humanity Rising with Roman Krznaric, who's written the book on how to become a good ancestor. So thank you, everyone. We'll see you same time, same station here tomorrow on Humanity Rising. Bye for now.